All right, so thanks a lot for the introductions and for having me to speak about the power of health economics. And really, what I want to give you in these next 10 minutes is really some insights about all these type of analysis are actually important and why we should really include an economic evaluation when we're conducting studies such as in regenerative medicines. So to start, I don't have any conflict of interests regarding that presentation. Let's get started. So why should we care about economics? And it's a very interesting question because almost all of our decisions in daily life include economics. Let's say with a basic example, if you need to buy a car, you will have the choice to buy that Toyota. That is great to bring you from point A to point B, but might not be the most comfortable car, not the most performant one, not the most flashy one. Or you can buy this Ferrari, way more performant, way more flashy, beautiful, but also way more expensive. And I hope that if you're deciding between buying a Toyota or a Ferrari, that you will consider the price of that car. It's going to be the same thing when you go for dinner. You can go to a cheap fast food restaurant with a meal that's probably under 20 bucks. Or you can go to this gastronomic Italian restaurant in a cave that might cost you $200 for a meal. Again, you will consider the price of the restaurants before choosing. Same thing for vacations. Do you want to go to the local camping sites, or you want to go abroad in that very fancy resorts with beautiful views, very nice hotel, and nice dining? You will, of course, consider the cost of these interventions because actually paying for one service means giving up another. So if you buy a more expensive car, you might not have as much money for leisures, for vacations. That brings me to the next question. Why should we care about healthcare costs? Well, for the exact same reasons, because paying for one service also means giving up another. But in that case, we won't talk about the type of car or the restaurant or vacation that you're going at. We will talk about, should we invest more in pediatric care? Or should we keep money more for home care for elderlies? Should we invest more in equipment to have more fancy, more updated MRI machines that can help us to diagnose a few conditions? Or should we give money, or should we keep money for medication, such as for rare disease that can be very, very expensive per patient? And what is even harder for policymakers and stakeholders in these decisions is that they don't have only to choose which healthcare service they will pay for, but putting more money in healthcare could also mean having less money for other services, such as services for homeless, building safe roads, money for educations. So we really have to care about the healthcare cost of the interventions that we're providing. And what is especially concerning is that the healthcare expenses are actually rising up. We see that in the past 5 decades, the proportions of the gross domestic product allocated to healthcare has nearly doubled in OECD countries such as Canada. And we actually expect that this proportion of the gross domestic product allocated to healthcare will continue to rise over the next few years if we don't make massive change in the type of services that we provide and in the type of where we allocated the money that we have. And that increase in healthcare costs is really driven by, well, first, the rising incomes for doctors, other healthcare providers, the technology innovation that is increasing, and the population aging that is requiring more and more care, so more expenses. And at the same time, we don't necessarily have better services. If we look at healthcare access, we can see that over the past few decades, our healthcare access is actually decreasing in Canada. The numbers that you see on the figure, it's the median wait time between a general practitioner referral to the service that's provided by a specialist, all specialty included. So in early 90s, that was about 9 weeks. Your GP refer you to see a specialist, could be like an orthopedic surgeon. In about 9 weeks, you can receive the treatment. Pre-pandemic, that waiting time increased to about 21 weeks. And the pandemic just has been an accelerator to that problems. And we see now median wait time that passed the 6 months barrier. And that is very concerning because being placed on a waiting list actually is not having adequate access to care. So we really have to find ways to improve the service that are provided without increasing the healthcare expenses. So what's the goal of economic evaluations? Well, the goal is really to ensure that our healthcare system provides to the population with efficient health technologies, health services, while rejecting or discontinuing those that are inefficient. An example could be the annual visit to your general practitioner, to your family physician. We now know that if you don't have any specific disease, these visits are not very efficient, and we start to decrease to discontinuing that type of service that have been provided. And let's go now just with a fictive example regarding regenerative medicine. So let's say if we look at PRP injections, platelet-rich plasma injections for knee osteoarthritis. If we wonder if that treatment is cost-effective, what we could do is we compare that intervention, the PRP injection, to a control, such as the corticosteroid injections. Then what we will need to do is to analyze the cost. So in that fictive example, again, it's numbers that it's not official numbers, it's it's fictive numbers. PRP, let's say, costs $950. The corticosteroid injection, $300. So it's an incremental cost of $650. Then the question that we have is the benefit of that PRP injections compared to the corticosteroid worth the $650? And if it's the case, we will say that the intervention is cost effective. It is something also that Jason will talk a little bit further in his presentations about the cost analysis. So then what we can do is we have a look at the difference in cost over the difference in effect. In that case, let's say the effect of the PRP on pain on a 0 to 10 scale is an improvement of 2 points compared to an improvement of 1 point for the corticosteroid injections. We will conclude that for $650, we have a decrease in 1 point out of 10 in pain. And then we have to analyze, is that improvement of 1 point out of 10 in pain, is it cost effective or not? And having these type of data will give us a better analysis, a broader analysis of the questions, and also to not only to focus on the clinical outcomes, but also to include the cost of the interventions, to really have a better decisions about should we pay in, should we provide that services to the populations. So just to conclude in my in that 10-minute presentations, well, the healthcare and the governmental resources are limited. Just like our own economy when we make decisions about the type of car that we buy or the type of leisures that we offer ourselves. And the problem that we see is that really the healthcare expenses are really rising up while the services are not. So we really need to include more health economic evaluations to really ensure that the service that we're delivering, that we're providing to the populations are cost effective, to ensure that we have sustainable healthcare services. And what I really recommend to you guys as a take-home message is when you're building up these research projects, don't focus only on the clinical outcomes. We are very good to analyze these clinical outcomes, but we had a tendency not to include those economic evaluations that are key, that are really essentials when we want to deliver or to include a new services. So if you're not familiar with doing these type of analysis, you can always collaborate with a researcher that is able to conduct that economic evaluations in collaboration with you. So that's all I had for you today. And of course, I'll be very happy to answer some questions if there are.
So a pleasure to meeting all of you, and I apologize for the small technical issue while I was trying to load up. So Simon has given you a great conversation and introduction to the concepts of economic evaluation, but economic aspects in health really extend beyond the ICER, the cost-effective sense. So what I'm trying to do in this next roughly half hour is giving you an idea about what are cost analyses and budget impact analyses, which are subcomponents that we will see from economic considerations. And like my subtitle says, you should care about them. So you need to consider these very strongly and quickly when developing your treatment. So, sorry, still having a technical issue. Okay, perfect. So basically our outline for the talk, cost analyses, budget impact analyses, and a broad conclusion. So cost analyses. So what is a cost? And I realize this question seems extremely simple, but from an economic perspective, it's extremely important to realize what can be considered a cost. So the generic information or definition would be the value of opportunity forgone as a result of engaging resources in an activity. The important key aspects here is we normally will consider what we spend for treating a patient, what we spend while someone is sick and we are trying to treat them. But a cost from an economic perspective is also what is foregone, what the patient is not producing, what are they not getting because they are sick. So both of these aspects need to be considered when we're conducting the cost analysis. So the cost analysis per se is the standardized process by which we identify these costs. Basically, that's it. It's really just trying to see how much money are we foregoing or consuming while treating a patient or because the patient is sick. This, I realize, seems extremely simple. The problem is defining these situations can be extremely hard. So one thing we need to keep in mind, and this really aligns to the Q&A part that we have between both stocks, is cost analyses will vary in function of the viewpoint we're conducting it from. And there are many perspectives that we can consider. So roughly, I'm giving you this very, very synthesized slide. We're trying to see that if you see on the left hand, you have a silo for patient. In the middle, you have a silo for Ministry of Health. In Quebec, it would be Ministry of Health and Social Services, but which also will account for hospitals. But if we were conducting this from a hospital perspective, a lot of expenses would not be considered. And on the right-hand side, we have private insurance. So this is something that is potentially less relevant in the Quebec or Canadian perspective, but in multiple situations, especially in adult active patients, and if we're considering the US situation, private insurance perspectives are extremely important. One thing I need to focus here is if you are conducting this in a Canadian context, the most important perspective you need to consider is either the middle part, so Ministry of Health, which includes the hospital, but also this umbrella term on top where you have this little city pictogram, which we call the societal perspective. So basically, if I was to simplify what the societal perspective is basically the umbrella term of everything. Because one issue we have to consider is the perspective is basically who's paying for the care. But what we don't want as a society is making sure that we're offering care in hospital, but transferring all of the expenses to the patient outside of the hospital. So the societal perspective is really that idea that we're trying to bridge everything, considering all the pros and cons in terms of money. So like I just said, once you define your study perspective, basically what you're trying to define is whose costs are you including in your analysis? Healthcare costs and cost analyses actually are relatively common in the scientific and gray literature. We have Ministry of Health reports, hospital reports. In Canada, we have the Canadian Institute of Health Information. I will put a caveat here that because Quebec data is partially included, sometimes we do have difficulty in getting back data from this website. But from a national perspective, I would say the CIHI website is one of the most important sources you can have. Problem is, a lot of what we have in terms of economic data in Canada and worldwide is for generic common conditions. Regenerative medicine often focuses on low volume conditions, rare conditions, where we basically just did not do any cost analyses yet. So if you are looking for this data, you might have trouble finding it. And more likely than not, you will actually be the ones that have to conduct these studies. So if you are planning to conduct these studies, there are a couple of variations that you can consider right now. And I guess we can go through these a little bit more in the Q&A part, but just giving you an idea. So one very common perspective, if we want to look for the Ministry of Health, is looking what was paid for by Ministry of Health across the country for specific patients that have the condition or that are getting the treatment that you want to consider. So what we would do is we analyze claim-based data. We have various versions of these. This could be public, private, multi-provincial. But one issue is because our healthcare system is mainly provincial in nature, a lot of these need to be considered from a province-specific perspective. Second option we can do is analyzing financial data from our specific hospitals. A lot of treatments that are being conducted or created from a regenerative medicine space are being used solely in hospitals. And one thing that is great about this context is our hospitals, especially in recent years, have really focused a lot on trying to get this data for specific patients. So we would have very limited issues regarding accessing the data. But one thing to keep in mind here is the hospital only manages the hospital in which it is being conducted. So any care that goes beyond our hospital system or beyond the specific hospital where you're conducting your analysis might be limited. And lastly, which is a thing I feel a lot of researchers forget, is getting care will incur cost to patients. We do have a lot of situations where healthcare, especially when we consider healthcare costs, especially when we consider foregone costs by patients, will not be collected in any data source. So what we need to do is contact patients and getting them to report these costs. Unfortunately, this is a little bit easier to say than to do, but basically these can be done prospectively and retrospectively in nature. So my very quick overview of cost analyses, because usually they are considered very simple, and I'm sure you understood the gist of it. What I want to focus now is really more the budget impact analysis, which is the complement of the economic valuation that Simone just presented. So what is a budget impact analysis? So it's an application of methods that are used to plan resource use and budget expenditure over a period of time. Basically, it's trying to say, if we adopt a technology, how will the budget change, either increase or decrease? In practice, this is it. We are basically subtracting two results. What is the cost in the context where the new treatment, the new technology is adopted versus the standard of care? The budget impact analysis is positive, meaning if the budget impact analysis is positive, what it means is that adding a new technology, a new treatment to the healthcare system will incur additional spending. If it's null, that has no extra cost. If it's below zero, we're going to have savings. In practice, most technologies will increase the healthcare system's cost. One thing I want to focus here on, because this is a very common misconception of health economics, the field does not ask that you always save money. We are extremely open to the idea that our healthcare budgets may increase, especially. I recognize that right now we are living in a context in Quebec where we are hearing a lot of issues regarding restraining our budget spending. But when we're considering new technologies, this is not necessarily a problem. We do recognize that if we're getting more care, we may be forced to spend more. Not gonna lie though, if you do manage to say that you're saving money, my job is a lot easier. So when you're conducting a budget impact analysis, there's a couple of aspects that you need to consider, which I've listed here, and then we're going to try to go through in the following slides. So features of the healthcare system. So one specific problem that we need to take into account is a budget impact analysis, like economic evaluations, are extremely specific to the systems in which they are being conducted. Budget impact analyses need to consider the specificities of our healthcare system. So, for example, here I have in the slide, we're talking about the fact that if we were to conduct an analysis looking at technology that would replace a drug plan or that would be included or covered by the drug plan. One specific issue in Quebec is that every Quebec citizen must adhere to a drug insurance plan. So we will be conducting this in the context of Quebec, where the full population will have a drug plan. If we were to conduct the same analysis in a different province, most of which don't force this issue, we would have very different results. So already I told you the results are scarce. They also have such limited scope that unfortunately they might not be relevant to the context of your study. Again, we will have perspectives, and the perspective basically refers to what costs will be considered within the analysis. In practice, the budget impact analysis should be based on the budget holder. We had during the Q&A, just trying, because this would not be recorded, context about costs incurred by patients. So in practice, budget impact analyses are rarely conducted from the viewpoint of the patient. They are mostly conducted from the viewpoint of a hospital system, healthcare system, or a provincial system. But all of these could be valuable in a sense. The question on which perspective should you use will really depend on what your market or key market is going to be. Third aspect that we need to consider is who uses the current technology and who would use the new technology. Again, this should sound relatively simple. Who uses the current technology is basically what's happening right now. What is the status quo? Who uses the current technology in the context where no other technology is available? The second scenario is a little bit more complex though, because if we're producing a new technology, more likely than not, it will not fully replace current standards of care. What could happen is you're going to have patients that will switch to the new technology. You will have new users that could not use the current technology that will now adopt the new technology. And you'll still have people that are going to say, I don't want to switch. I will remain on the current technology. So my job is not to propose to you how to make sure people switch, but to account every different perspective or every different choice that could account or could occur were you to bring your technology to market. This, however, is a lot harder to do than what I'm trying to say. So we have to predict these based on simulation work. We have to predict this on market valuations, and it might be off. Scenarios exist to try to account for this, but this is one of the more subjective inputs in the whole BIA. Lastly, on this point, I want to mention is there's no reason why both numbers of patients in both scenarios will be equal. And like I said, more likely than not, we're producing new technologies to answer situations where there is some unmet need in the patient population, which could potentially lead to greater number of patients getting access to care. Fourth aspect we have to cover is the time horizon. So budget impact analyses have extremely short time horizons. In Quebec, being all in Quebec, we recommend between 1 and 3 years, depending on the context, depending on what organization you're submitting this to. But in Canada and internationally, we will also often see up to 5 years following the adoption or the reimbursement of the technology. This is really important because the time horizon in budget impact analysis is a lot shorter than what we would normally see in the economic evaluation. Economic evaluations will tend to focus on the whole lifespan of a patient or the whole lifespan of the technology being used. Whereas the budget impact analysis, regardless of the technology's lifespan, will only focus in the very acute time frame following its adoption. One point that we need to discuss is the context of discounting. Economic evaluations, if you're familiar with this, are must examine discounting. So discounting is a concept in economics where we try to value the temporality of the gains and the expenses. Luckily for us, and where I'm trying to skip this here right now, is that budget impact analysis, unlike economic evaluations, will not consider a discount. What it will consider, though, is if you have changes in costs. One thing you have to consider is if you're doing a budget impact analysis regarding a technology you're producing, you have to consider what are the alternatives you have. And alternatives, especially in the context where we can have, Preventive or, sorry, my last words. I'm gonna skip this. Sorry about that. A little bit rusty. But because you can, patents, sorry. So because we have patent laws and we can have issues where patents get discontinued or stopped prematurely, you have to account for these issues regarding your discounting. The validation step is probably the simplest one. All budget impact analyses, like economic valuations, are mathematical models. So basically, the validation step is making sure that all the inputs and formulas you're using in your model make sense. So if I put these two concepts side by side, I think it's going to give you a better idea, even though I've tried to go a little bit over these during my talk. So why do we do a budget impact analysis? We're trying to say, do we have the budgetary capacity to add a technology in our healthcare system? The economic valuation on your end is this good value for money? So complementary in nature, but completely different. Like I said, our goals are in the BIA is to plan the budget, whereas in the economic evaluation, we're trying to determine the relative efficiency of comparators to see, like Simone mentioned, should we discontinue or stop potentially obsolete technologies. In a budget impact analysis, one point that is very important and that really differs from an economic evaluation is that we don't care in the budget impact analysis what are the clinical benefits of the technology. We're only looking at the cost. The considerations for patients, the considerations for the healthcare systems in terms of added values for clinical value are only considered in the economic evaluation aspects. Like alternatively, in the budget impact analysis, we'll look at the whole healthcare spending from the perspective we're looking at. Whereas in the economic valuation, we have what we just saw earlier on, the ICER, so the added cost per unit of effective. And like I said, time horizon wise, a lot quicker in the budget impact analysis and extremely longer in the economic valuation. So going back to the simplified example that Simone showed you at the end of his talk. So what he showed you earlier on was that PRP had an added cost of about roughly $650. And that you could save 1/10 or a 1 point on a scale from 1 to 10 pain. So the ICER in that context was that for every time we're using PRP, we have to spend $650 more to save 1 level of pain on a scale from 1 to 10. That was the ICER. Is that good value or not? I cannot say. But decision makers will try to assess this in the sense that if we are willing to pay $650 or more per point decrease in pain, this is cost effective. If not, this is not cost effective. The budget impact analysis in this context is a little bit different. So if we go back to that slide, you have that PRP, for treating one patient with PRP, it would cost $950 per patient. So the budget impact analysis, let's say we had in our healthcare system 1,000 patients. That would mean that the budget impact analysis would be $950,000 to treat 1,000 patients with PRP versus, if I'm not mistaken, it was $300 per patient, so roughly 300,000 patients. So the budget impact analysis in that context would say that we would be raising our healthcare budget treating patients with PRP by about $600,000. So roughly tripling what our initial budget is. This brings really a good question to mind. So what do we do when we have conflicting views? In a perfect sense, what we're hoping is that the economic evaluation is going to be positive and that the budget impact analysis is going to be low. In practice, we might not have these situations. You might not know if it's going to be cost effective or not, and you might have situations where the most cost effective option could be extremely expensive. And this is an issue, unfortunately, I fear could happen a lot in the regenerative medicine space. So you need to consider these very earlier on, because you're not, like I said, the fact that this occurs is not a deal breaker, but is certainly something that you need to think about to prepare when you're presenting these to regulatory bodies. So why do we need all of these studies? And here I list only cost analyses and budget impact analyses, but I should definitely be adding the economic valuation as well. Well, the simple reason is because at the end of the day, you'll need them. So we do all of this because whatever technology you're developing, we want to bring to market. Right now, a lot of the focus is on making sure the regulatory body, let's say Health Canada here, will say that your technology is safe. The problem is, if it's safe, it does not mean it's going to be sold. Most healthcare systems, especially public healthcare systems, have some HTA bodies that will have to examine, is this a good idea? And if you're planning to sell your treatment in Quebec, in Canada, you're going to have this HTA body that's going to assess this and say, despite the added costs, the fact that we feel it does provide great cost for value, cost effectiveness, is a cost efficient treatment, or potentially other considerations, we will say yes and we will say no. So this is something that you need to think about right now, because at the end of the day, creating new treatments but not getting them adopted by the system questions on what the value of the treatment is. So, like I said, the HTA body will look, of course, at the clinical effectiveness. We don't necessarily, or I will say very rarely, adopt technologies that aren't clinically effective. And this, I think, is something that everyone here agrees. We want that technologies that will be effective, that will help patients. But beyond these, they also examine different aspects. They will examine the ethical and legal considerations. Is there an issue with accessibility across the country? Is there an issue with ethical barriers or language barriers that could be considered important to consider? We're going to have organizational aspects. Let's say you're developing a technology that would ask that we would raise our power structures across the country tenfold, potentially unfeasible regardless how good it is. And lastly, we will examine the economic aspect. So all of this, and this is really a sales pitch for Mathilde and other researchers also in the ethical legal side, you need to consider all of these in your technology, because the HTA body that will assess this will examine this. And keep in mind, I did mention this, that HTA bodies are mostly focused in Quebec, Canada, and public healthcare system. But private organizations, private insurance companies will also have these aspects being considered. So one issue, however, you could say is we are extremely rare. So experts in economic evaluation, like Simon and I, are unfortunately too rare for what the demand is across the country. So recently, and this is more of a sales pitch than a very long slide, my team has really worked on trying to develop tools that help researchers in fundamental space that might not be able to access us to conduct their very simplified budget impact analysis, so that you can do these initial steps right away. So we basically created two tools through a project that was funded by TCL and the Stem Cell Network, trying to create a simplified web tool, which accessing this will be online through the Réseau TCL website, but you will basically have to ask 5 small questions and it will give you a result very quickly. And a more complex tool just gives you a little bit more update on what you need, how to consider these aspects. That will be Excel based that you can download on our website. So both tools, the documentation and video tutorials, are to be made freely available to researchers on the Réseau TCL website, honestly, very soon. So thank you very much for listening to my talk, and I hope if there's any questions I can answer. Thank you very much.